My name is Dr Flanagan. I'm an otologist, and essentially what that means is I have an interest and an expertise in the management of hearing loss in both adults and children, and all the associated diseases that affect the ear and the surrounding structures, even the nerves that connect the ear to the brain. My training has been based in Sydney, but I did do some additional training overseas in Italy and came back and set up a practice here in Sydney associated predominantly with St Vincent's Hospital, both public and private. I also consult in Miranda in the Sutherland Shire once a week and have a public appointment at Sutherland Hospital and St George Hospitals, and also operate once a month down at Carina Hospital as well. Whilst perhaps almost obvious, the importance of hearing is essential from the very beginning of our life until the end. As a young child, speech and language development is essential. As we get through life, it is being part of the community and work and being able to communicate with friends and family. And as we get older, there is certainly a very good correlation between the level of hearing and engagement in the environment and the link with early dementia. So optimising people's hearing is both rewarding and challenging, and certainly very important in what we do. While we manage a vast array of conditions affecting the hearing, there is a small but very important group where the hearing is particularly bad, despite the use of hearing aids, appropriate medical treatment, and even surgical operations sometimes to restore the hearing. Now, these people have been often fitted with hearing aids and work very well with a good audiologist, but nevertheless are unable to hear in an appropriate fashion. Essentially, it's a hearing aid, but it stimulates the nerve of hearing directly. And it is made up of two parts. One, an implantable component that has a very fine electrode that is fed into the cochlea and stimulates the nerve of hearing directly. There is then an external component, and this is essentially the processor or the hearing aid part, and it converts the sound wave into an electrical signal to allow the brain to be stimulated appropriately. Patients with severe inner ear damage affecting the hearing, where a normal hearing aid is really just not providing the appropriate amount of hearing. And people often say, I can hear noise but not speech. I can't talk on the phone anymore. I really struggle to engage in an environment where there's anything more than complete silence. And eventually patients or people describe becoming more and more withdrawn from society because it's just too hard to listen, and thus participate in normal day-to-day activities. So there are a few misnomers. Often patients will say, I'm too old, this is too complicated, the surgery is too risky, it's way too expensive, I can't access that sort of technology. But almost all of these are misnomers, and with appropriate management, these things can be overcome if you are an appropriate candidate for such a device. No longer do we keep cochlear implants purely for patients with no hearing whatsoever. Now, whilst this may sound slightly technical, the advantage of a cochlear implant becomes apparent when we test hearing with hearing aids in, and we ascertain the degree of words correct or sentences that people can understand. And when we are getting to less than 60% or 50% of those words and sentences correct with a really good hearing aid, we know then that a cochlear implant has a very high chance of providing a much better level of hearing. Having said all these things, the decision to proceed to cochlear implantation can be a difficult one. It is a surgical procedure requiring delicate microsurgery, albeit these days, for us, it's a routine procedure. An overnight stay in hospital and the switch on of the implant the following day are now almost routine. The hard work is not mine, however, it is yours. Essentially, this requires an extended period of retraining, working with the audiologist, getting the brain to, and the ear for that matter, to relearn how to hear again. And this may well take a number of months, if not longer, until we really get an idea of how good the improvement in hearing is. One of the important things is working with an audiologist. Now, if your or your child's audiologist is not experienced in cochlear implant mapping, our team here has a vast experience in both the assessment and the ongoing rehabilitation required. So really, the first and most important thing is to truly assess the level of hearing with current technology and medically stabilised ears and hearing. And occasionally this does involve other testing, including MRI scans of the brain and the inner ear, and sometimes even balance testing as part of our medical workup for such an intervention. My practice is centred around the management of hearing loss in young children as young as 6 months all the way to extreme old age. Now, whilst there is a vast number of causes of hearing loss and associated diseases, I'd like to highlight a few really important points and both common and important disease processes that we deal with. The first is the management of otitis media with effusion. Now, another common name of this is glue ear, and is commonly seen in younger children where they are exposed to head colds, blocked noses, and this leads to the build-up of fluid behind the eardrums. Now, most of the time this will clear spontaneously or with an appropriate nasal spray or antibiotics, but if this fluid remains present for more than 3 months at a time in both ears, it starts having significant impacts on speech development and also can lead to the development of middle ear problems, scarring, and affect long-term speech and language development. So how do we manage this surgically? Well, occasionally this requires the insertion of ventilation tubes or grommets. This is a surgical procedure where we insert a small plastic tube through the eardrum to drain that fluid. Now, often in concert with this, we treat the adenoids, some tissue at the back of the nose that can affect the drainage of the fluid from the ear. So when these grommets or tubes do grow out of the ear, as they almost always do on their own, the likelihood of us ever needing to put grommets back in is very small indeed. So like any surgery, it is relatively routine for us, but not for the patient involved. So it does require both delicacy at the time of surgery, but close follow-up for the months to years after the surgery to ensure that the ears return to normal function without our help into the future. This is a surprisingly common condition where people can, within hours to days, notice a sudden and often catastrophic drop-off in the hearing in one ear. This for us is an emergency, as rapid institution of both oral steroids and occasionally injecting steroids into the ear itself can give us the best possible chance of salvaging or even returning hearing to normal. Now, it can be difficult sometimes, as that blocked feeling can be the same as you might get on an aeroplane or after a head cold or some wax getting stuck in the ear. So both us, GPs, and yourselves need to be mindful that if there's a sudden drop-off in hearing, prompt analysis of the hearing aid, seeing one of us, is very important. Occasionally, this can be the marker of a more serious condition as well, and often as part of the treatment and management we would organise specific blood tests and even scans of the ear and the brain to rule out these serious problems. Now, essentially, this is an arthritis of one of the three bones of hearing. These are designed to amplify sound as they go into the ear. And the third bone, the stapes, in fact the smallest bone in our body, can occasionally become stuck. This causes a progressive hearing loss and almost always affects the conductive part of the hearing, not the nerve. Now, this presents us and you with the option of improving hearing either with a hearing aid or with surgery. Now, surgery is not for everyone, but it gives us a great opportunity to return the hearing to normal by bypassing the third bone of hearing that's stuck. Now, for us, this is one of the most delicate and rewarding surgeries that we do, and involves lifting up the eardrum, using a laser and a micro drill to create a hole through the base plate of that bone that's stuck. We then replace that with a tiny piston, re-establishing the vibratory quality of the ear and essentially returning hearing to a normal level. Occasionally, this same condition many years later can also affect the nerve of hearing, and in this particular case we would then reconsider the idea of hearing aids many years down the track. So who benefits from surgery? Well, those who are active, who are relatively young, have an aversion or don't really wish to wear a hearing aid, or in fact have issues with irritation or retention of a hearing aid in the ear itself. Obviously, these decisions are often complex and things that we would discuss in detail both with your surgeon as well as an audiologist. The commonest cause of adult hearing loss is noise exposure and age. Now, most of these levels of hearing loss can be ameliorated or managed with a hearing aid, but also most of this can be preventable to some degree with appropriate noise protection and care with noise exposure throughout one's life. The important thing, however, is if the hearing is asymmetric. And if this is the case, this requires close and careful evaluation to rule out the unlikely but possible presence of significant underlying pathology. And essentially, what I'm talking about here is making sure that there is no nerve tumour or growth on the nerve of hearing and balance. Now, this requires an MRI scan in almost all cases, and if we did find something here, then fortunately, more often than not, these tumours do not grow significantly, can be managed conservatively, but occasionally they do. We detect them at a large size and require a very careful discussion regarding management, which often includes the choice between surgery or radiotherapy, or often a combination of both. A very important part of our management is assessing the patient who has a difference in hearing in one ear or the other. Now, most of the time this is self-evident. On examination, we can remove wax, we can repair some minor issues with the hearing mechanism. But if the nerve function on one side is notably different to the other, whilst almost always not the result of a major issue, it can represent the presence of a small to large benign tumour growing on the nerve of hearing and balance. And thus, anyone with asymmetric hearing loss of a nerve type, it is very important for us to organise an MRI scan to rule this problem out. If we did identify such a problem, it is a condition called an acoustic neuroma or vestibular schwannoma. And more often than not, these are small, do not grow and require observation. Occasionally, this is not always the case, and the management of these tumours can be complex and often require both surgery and radiotherapy options for the best possible management. And we'll cover this particular condition in more detail in a later presentation. Basically, it's a surface ear, and it's the result of exposure to cold water and wind, and this leads to the formation of bony lumps. As they grow, the ear canal narrows progressively, and we can often end up with recurrent water obstructions and even painful ear infections, and at the end stage, complete and permanent obstruction of the ear canal and hearing loss. When all sensible measures fail, such as earplugs and drying agents, we then consider the role of surgery. Now, this has often been thought as super painful and high risk. With delicate surgery and approaches, this is now essentially a routine surgery with minimal pain. You can get back in the water and swim and surf very quickly. The big thing to consider though is the ear will be blocked from a hearing perspective up to 6 weeks. So we can ensure that the skin of the ear canal heals appropriately to create a wide, patent and well-functioning ear into the future.